Hello everyone, welcome back to my channel. So today's topic will be bleeding. It is a very most important topic in GIT medicine. So we'll be studying first upper GIT bleeding. So what is bleeding? Blood loss from any part of the GIT from oropharynx till anal canal. So any part, it can be upper GIT bleeding or lower GIT bleeding. And the upper GIT bleeding and lower GIT bleeding is distinguished based on the ligament of Treitz, and it is present at the junction of duodenum and jejunum. So if the bleeding is present above this ligament, so it will be upper GIT bleeding, and if the bleeding will be lower than this ligament, so it will be lower GIT bleeding. So upper GIT bleeding is a very emergency condition and should be treated on the urgent basis. So a person can be presented with various symptoms like hematemesis. What is hematemesis? So hematemesis is a blood in the vomiting. It can be blood with clots or black. So if it is present with the blood with clots, it will be severe bleeding, like in esophageal varices. And if it present in like black vomitus, so it is less severe. Second is melena. Melena. What is melena? Melena is a blood in feces. It is not the fresh blood, but in hematemesis, it is fresh blood. Why in melena it is not fresh blood? Because it will travel from upper to lower and the digestion of the blood will take place. So on progressive movement, it will convert into the black tarry blood. So it is melena. Person can be presented with hypotension. Hypertension can be due to any chronic bleeding in the body and it cannot be identified. So it will lead to the iron deficiency anemia. Can be present internally anywhere. Synchrome, a person can fall again and again. So these are the symptoms. What are the causes of upper GIT bleeding? Can be esophagitis, inflammation of the esophagus, can be liver cirrhosis. Liver cirrhosis leads to like a person is suffering from portal hypertension. So all the blood will flow towards the superficial veins of the esophagus. So esophagus will rupture and lead to the esophageal varices. So it will be fresh blood. Can be third cause can be peptic ulcer disease like duodenal ulcer, gastric ulcer. Gastric ulcer is due to left gastric artery rupture. Duodenal ulcer can be due to gastroduodenal artery, and the most common reason of upper GIT bleeding is peptic ulcer disease. Fourth is gastric erosion, like due to continuous use of the NSAIDs and alcohol. Fifth is Mallory-Weiss tear. Sixth is vascular malformation like aortic aneurysm, AV fistula, and it can erode in the duodenum. Seventh is dilaphoid lesion, like sudden onset massive painless bleeding in the body. So what are the protocols can we perform to the patient? So first we'll provide the IV access. IV access like we will access the large bore cannula in the patient and can be resuscitated later. Second is initial clinical assessment. We can do like circulatory, liver clinical assessment, comorbidity, circular status like pulse, BP, tachycardia, or person has cold peripheries, liver cirrhosis like we can visualize the person like from ascites and hepatosplenomegaly, comorbidities like renal failure, cardiac failure. Third is baseline investigation. Baseline investigation can be done by taking complete blood count of hemoglobin. If it is acute, HB does not alter in the acute cases, but in chronic cases, HB will be altered very much. But HB is not a good indicator, so we will do hematocrit. Uh, Second is urea electrolytes in kidney failure like liver function test, prothrombin time, cross matching. Fourth is severity access. Severity access can be accessed by BP, respiratory rate, pulse rate in every hour. We have to do it every right. So we will search like a person is having blood loss or not. In the 10% of the cases, it is tachycardia. In 20%, it is tachycardia plus hypotension. Or 30% or more, it will present with a shock. Fifth is resuscitate. We can resuscitate by the fluid normal saline or linger lactate. HB poor indicator. HB is a poor indicator and we cannot rely on the HB indicator. So we will do hematocrit. We can rely on the hematocrit. So if it is less than 30 bleeding, like bleeding time or in the elderly patient, if it is 20 to 25, so in adults. We will provide oxygen face mask. We will provide fresh frozen plasma, platelets, and it will depend on the patient what we will provide. We can do PPIs, the proton pump inhibitors, octreotide in POD cases. But till now, by these protocols or these causes or these symptoms, we have not identified the perfect location in which a person is suffering from bleeding. So for the location, we will do endoscopy, and we have to do endoscopy within 24 hours of the cause of bleeding to identify the cause. Endoscopy is diagnostic as well as therapeutic. In endoscopy, if found PUD, if the person is suffering from peptic ulcer disease, we will provide dual therapy like heat probing, endoscopic clips, and adrenaline injection. And if it is esophageal varices, we will provide banding in the case of varus location. We will provide sclerotherapy with the help of sclerosing agents. And if not stopped, by these methods also, if the bleeding is not stopped, we will provide balloon tamponade. In these cases, in the dual therapy, after dual therapy, we can provide homeospray also, which is a rescue therapy, ultimate rescue therapy. And if not controlled, then definitive treatment is always surgery. So if it is gastric ulcer, we will provide stitching at the site of ulcer under running surgery or gastrectomy. If it is duodenal ulcer, we will provide in under running surgery like pyloroplasty. We have to do continuous monitoring until the patient is in stable condition. If it is a case of NSAIDs or H. pylori, we will provide H eradication therapy like PPIs. So this is the upper GIT bleeding. It is a very most important topic. In the next lecture, we will study about the lower GIT bleeding.